It's UofL Today on 93.9 The Ville. Here's your host, Mark Hebert.
And welcome to UofL Today with Mark Hebert. So glad you're joining us. We have a packed show today. We've got three guests that we're going to pack into 30 minutes, so I hope you'll stay with us. I hope you'll learn something. We've got all the positive news about all the great things going on at UofL in terms of research, great students, and events going on. So welcome to all of you who are listening on 93.9 The Ville, and those of you who are watching on Metro TV. Hopefully you'll go away just a little bit smarter after this show. So let's get right into it. We've got a lot packed into 30 minutes. Today, three faculty members and three different topics. One of our guests, Dr. Roland, will discuss the confusion for women over those new recommended guidelines and when they should start getting mammograms to detect breast cancer. Also, history professor Daniel Krebs will be here to talk about U.S. military history, and I'll be asking him about the impact of Vietnam, Iraq, and Afghanistan on Americans' view of war. But first, Dr. Rahul Bhola is with us. He's the director of pediatric ophthalmology in the UofL School of Medicine and a pediatric eye specialist with UofL Physicians. He's an expert on vision problems in children. Well, welcome, Dr. Bhola.
Oh, thank you so much, Mark. Thanks for having me here.
Glad you're here. Glad you're here. And I think this is a topic that a lot of parents who are listening to this and watching this will have a little bit of interest in. So, what does the director of pediatric ophthalmology mean? What do you do?
So pediatric ophthalmology is actually an integrated field with adult strabismology. So we see not only kids with all vision issues, but we also see adults, who have double vision and misalignment of eyes and who had strokes and then double vision subsequent to that. So it's an integrated field. We see kids with not only vision issues, but we do all comprehensive eye exams for kids where we check for eyeglasses and any pediatric issues, and we treat that.
You mainly concentrate on kids and their eye issues and vision issues, correct?
Yes.
You've done some research and you do surgeries on children with glaucoma, correct?
Yes,
well,
absolutely.
Why don't you talk about that a little bit? Because I think most people think of glaucoma, they think of guys that are older than me getting glaucoma, not children.
So that's very interesting that you bring this topic for discussion, because glaucoma, as you said, people have this notion that glaucoma is a disease of adults, it doesn't affect kids. But that's not true. We see a lot of kids with glaucoma, some of them after trauma, sports injuries, and that's something that parents should definitely consider getting their eyes checked after some sports injuries, because I have a lot of kids in my practice who had even trivial trauma to their eye and developed glaucoma even up to 2 to 3 years after the trauma. So unfortunately, it goes undetected, and by the time we see these kids, they have had irreversible vision loss. So it's important to catch that early and treat that promptly. Now, not only trauma, but glaucoma can be present in kids. They can be born with glaucoma, which is what we call as congenital glaucoma. There are kids who can have developmental glaucoma or juvenile glaucoma, which is something which I see a lot in Kentucky, especially in the African American population. There's a gene which is quite prevalent in the African American population here in Kentucky, which these kids actually start having glaucoma in their teen years.
Really?
And unfortunately, that's not detected at that age, and by the time we see them in adulthood, they have significant vision damage causing a tunnel vision.
Well, is this more widespread, glaucoma in kids? Is that more wide? I assume it's more widespread than I thought, because I didn't even know kids could get glaucoma. But are there a lot of kids in Jefferson County and Louisville that have this, or is it pretty widespread?
I would say I see at least 10 to 12 kids every month, with new onset glaucoma. So even though it is not as common as something like cataract, which we see in adults, but it is common enough for us to diagnose that early and treat that, because it's a blinding disease.
So how do parents know?
That's a great question, and unfortunately, kids at that age don't know that this is something that's not normal for their vision. Now, some kids can have headaches, excessive headaches, they can have a pain in their eyes, they can have vision changes, but a lot of these kids actually go undetected, and that's why it's so important to do these comprehensive eye exams, which, by the way, is mandatory in kids of Kentucky. And at least in the state of Kentucky, every child gets an eye exam before the age of 5, which is an excellent thing that we can detect that early via that route. But I guess that it's just the pediatricians should be made aware of this disease and they should catch these signs.
We're talking to Dr. Rahul Bhola from the University of Louisville School of Medicine and also UofL physicians. What are some of the other things that you see, vision problems that you see in children that are very prevalent or might be more prevalent than we think they are?
So you'll be surprised that 20% of kids in Kentucky have some sort of a vision issue, which could be a refractive error or need for glasses, like nearsightedness, farsightedness, or stigmatism that needs to be treated. But there is another very common entity which goes unnoticed, which is called convergence insufficiency, which a lot of these kids complain of headaches after reading. And unfortunately, they get $1 million workup for headaches, including an MRI of the brain and whatnot. But in actuality, it's just the muscles of their eye which are weak. And when they read, they have to exert a lot in order to read. And prolonged hours of reading can cause headaches. So this is something which can be easily picked up and very easily treated, even with home exercises. To strengthen those muscles of the eyes, and so it's important to again diagnose that.
But you got to get your kid. You got to get your kid to an ophthalmologist.
Absolutely, especially with headaches and those kind of things. You should start with an eye exam before you do $1 million workup. So.
I got you. You also talked a little bit about smart devices. I mean, a lot of parents are worried if their kids sit in front of a computer all day or watching TV all day. Can that affect their vision?
Yes, it can, and you'll be very surprised that there has been an exponential increase in the incidence of nearsightedness in the Americans in general. And one of the important reasons for that is prolonged usage of smart devices. So what happens is that when kids are using these devices for a long period of time, it exerts an excessive pressure on their near focusing mechanism. And when that happens, that causes increase of the growth of the eyeball, because they are using these muscles on an excessive basis. And what that translates into is nearsightedness, which is myopia. And so that's why we are seeing. So my rule, and I always educate that to the family, is what we call as a 20-20 rule, that after every 20 minutes of usage of these devices, you should have a 20-second break. You should just relax for 20 seconds. Just take your eyes away from the near targets. Maybe look in the distance, just close your eyes, and that should be something which should be used as a generalized notion, for kids who do a lot of reading and use these smart devices, because we want to relax their eyes.
How old are we talking about that this 20-20 rule should be implemented by parents?
As soon as the kids are starting to read.
Really?
And
okay.
yeah, so the American Academy of Pediatrics has come up with this rule that entertainment-related media should be restricted to 2 hours at the most in a day. Which I agree with, but the only problem is that these days a lot of educational things are happening on smart devices, and we are using these smart boards in schools. So I think the most important thing is to make sure that you're not using these on a prolonged basis. You have to get these breaks in between, and that's vital.
All right, so what's the most important advice as we get ready to wrap up here? What's the most important advice that you would give to parents, other than they have to get this eye test before their kids are 5, I think?
Right.
Other than that, what other?
So as you mentioned, the most important thing is, of course, is to be aware of signs of vision problems, like your child is squinting excessively, standing close to the TV, is complaining of headaches, tilting head towards one side, closing one eye for watching near things, eyes watering quite a bit, have a lazy eye, like eyes drifting outwards, crossing of the eyes. You should definitely seek an eye exam at that point in time from an ophthalmologist. But in general, I think you have to be very careful with these smart devices, as we discussed, that limit their usage. You cannot, I'm not saying that just take them away from the kids, but limit their uses and don't let them use them for prolonged hours. And definitely you can go to our website, UofL4kids.com, for further information. And if you need an appointment for your child to be examined, you can be reached at 502-588-0550. That's our phone number. for getting an appointment. And I would encourage definitely to have a healthy lifestyle.
All right, very good. Dr. Rahul Bhola from UofL School of Medicine. Appreciate it. Thanks for coming on.
Thank you so much, Mark. Appreciate
All right.
that.
When we come back, the new confusion over mammograms and breast cancer. You're listening to UofL Today with Mark Hebert on 93.9 The Ville.
My name's Natalie. I'm a junior studying communications at the University of Louisville. UofL has given me mentorship opportunities. I'm in the honors program. I've had a lot of opportunities through that. I got involved in Greek life. I'm a Cardinal ambassador, so I get to show people what I love about our university. And then I'm also on the student orientation staff, so I get to work with the incoming freshmen and calm any of their nerves about college, and just show them my passion for UofL and hopefully transfer that to them. Family is really what it's all about here at UofL. Go Cards!
We're back on UofL Today with Mark Hebert. You may have heard the recent news from the American Cancer Society that women should start getting mammograms at age 45, and they used to say it was age 40. Other medical groups have recommended age 50 or 40, so what is a woman to think? Dr. Lane Roland is with the UofL School of Medicine. She's the Director of Breast Imaging and Intervention at the James Graham Brown Cancer Center as well. So, Lane, welcome.
Thank you.
Appreciate you being here.
Pleasure to be here.
All right. This is very confusing, I suspect, for women, that the American Cancer Society came out with these new guidelines and said, all right, you don't have to get a mammogram until you're 45 now, where it used to be 40. So what should they believe?
Well, first of all, I think it is very confusing for women, and there's a new website called End the Confusion, which may help some people, so I'd like to refer people to that. And then I think the important thing to note is that the American Cancer Society has always and continues to support annual screening mammography with the option of beginning at 40. They do acknowledge that that provides the most lives saved and most life years saved. So the recommendation says 45, but says that it should be offered age 40 to 44. So it's
that just confuses things more, doesn't it? Because what you're telling, what message do you hear as a woman when that is said?
Right. So we, along with breast experts and imaging experts, continue to recommend annual screening mammography beginning at age 40 and annually thereafter, because that is the most life years saved. It is not uncommon for different organizations to make different recommendations based on what they value. So if they value lives saved, they say 40. If they value potentially cost or overdiagnosis, which is grossly overestimated, and we can talk more about that, then they may say 45. But no one argues that the most women are going to be saved. The breast cancers are going to be found smaller before they're palpable when there's less aggressive treatment needed, such as mastectomy and chemotherapy, and they're more likely to be cured beginning at age 40.
So what are you telling your patients?
40.
40, you are.
And for someone,
is the safer thing to do?
It is the safer thing to do. And I think, they talk about average risk women. Well, the woman that gets breast cancer, by default, the majority of time is going to be an average risk woman. Only 1/4 of the time does that woman have any risk factors such as a BRCA1 or 2 mutation, radiation exposure, or family history. So the vast majority of times, your main risk is being a woman and getting older, and we can't do much about that, or it beats the alternative anyway. So if we only screened high-risk women, many women would unnecessarily die of breast cancer. Across the board, there's a 35% reduction in mortality shown by multiple rigorous randomized controlled studies, which are very good studies over the years.
How many women in Kentucky are diagnosed with breast cancer each year? Do you know that number?
It's nationwide, it's 40,000 die and 230,000 roughly are diagnosed.
But you said earlier that there are false positives, a lot of false positives in.
There are some false positives, certainly, but I think women can feel reassured in that if I read 1,000 mammograms, 80%, 100 people are going to be called back. Of those, 80 are going to just have a follow-up exam or an ultrasound and be cleared. 20 will undergo additional workup to include a biopsy or something like that, and of those, 5 will be diagnosed with breast cancer.
So 5 out of 1,000.
Right, so 5 out of 1,000 roughly. And of that, they've done multiple studies on women that have been called back for a false positive exam, and there is some anxiety associated with that, but it's been shown to be temporary, and even of the women who have been called back, they still recommend and want to be screened and know their status. And that anxiety has been shown to dissipate with no long-term effects. So it would be hard to argue that the harm of short-term anxiety with no long-term effects outweighs the benefit of a 35% reduction in mortality from breast cancer.
We're talking to Dr. Lane Roland, who's the Director of Breast Imaging and Intervention at the James Graham Brown Cancer Center. What about men?
Men do get breast cancer, and it's very important for all of the men out there to know that. It's about 1% of all breast cancers, but we see a lot of it. And it is important for men because they don't have breasts. There's no screening guidelines or recommendations, but just like women should be aware and comfortable and know what their breast looks like, men should too. If there's any change in a man, a palpable lump, nipple retraction, nipple discharge, anything that feels weird, unusual, they're just not certain about, come on in, we're happy to screen them and make sure it's nothing.
And 1% of all breast cancers are in men? That's correct?
Correct.
Wow. I had, that doesn't sound like much, but then when you think, a lot of people didn't even think that men could get breast cancer. So do you see a lot of those patients?
We do, and they are treated and staged just the same as women, and it is equally important that they don't ignore anything and come in.
Okay, and let's get back one more time on the guidelines for women. You were telling your patients 40 years old, come on in, get a mammogram. Are insurance companies, now that the American Cancer Society has gone to 45 is when you should get your first mammogram, or they recommend, are insurance companies going to cover your patients who you tell, hey, it's 40 that I want you in here?
As of now, they are still covering it because the task force has given it a B instead of a C. There is risk long-term that they may not be covering it and that women may have to pay, but as of now, it is still covered. There is literature and plenty of literature to support screening, and even the task force and the American Cancer Society realize and recommend that. So I don't think there's harm in the near future, but it is a danger long term based on cost, and cost reduction in healthcare is a big thing right now.
It is. All right, what's the new technology in breast imaging?
So there's lots of new technologies in the fight against breast cancer. We have to attack breast cancer both at the screening level and also at the treatment level. So I'm going to speak about the screening side of it. There's a new technology, it's a few years old now, but called 3D mammography or digital breast tomosynthesis, or simply TOMO. And what that is it is a type of screening mammogram that takes multiple pictures of the breast at different angles, and it reconstructs those into little 1 millimeter slices that we can then scroll through, eliminating some of those false positives by decreasing overlapping tissue and allowing us to see through the tissue better to get a clearer view. It allows us to be more confident in who we call back. Multiple studies, the research is still early, but it's reproducible and reliable, and there's quite a bit now that shows reduction in recall rate of 30% and an increase in cancer detection rate of 15%. And both of those are significant because when we talk about these potential harms of false positives, if I can reduce the number of people I'm calling back by 30%, that's quite significant. And in fact, it may help in the future maintain coverage for women.
And are there any new studies or any new research about what role heredity plays in breast cancer?
There's a tremendous amount in risk stratification for women and genetic screening and genetic counseling. There are all kinds of, we're finding new genetic links and all the time. So women, when they come in, if they meet certain criteria, we refer them to a genetic counselor. If a woman is found to have a BRCA1 or 2 mutation or some of the other mutations that are less common that people don't know about, but we start screening them earlier at age 30 with both a mammogram and MRI, annual screening breast MRI. So women that are at high risk qualify for additional screening because we know they are going to get more aggressive breast cancers earlier, which we need to use the breast MRI and other tools to find earlier.
All right, Dr. Lane Roland, any final words of wisdom to the women and men out there about breast cancer?
Absolutely. Just don't ignore any problem you might be having, and don't wait till you're having a problem for women. It is well worth coming in and getting screened and reducing your risk of dying from breast cancer.
And if we come to you, you're going to tell us to do it at 40.
Yes.
Maybe not me, but my wife.
Correct.
All right, very good. Dr. Lane Roland is with the UofL School of Medicine and the Director of Breast Imaging and Intervention at the James Graham Brown Cancer Center. Thanks for being with us. Appreciate it. All right, we're going to take a break, and when we come back, we'll talk a little U.S. military history. You're listening to UofL Today with Mark Hebert on 93.9 The Ville.
This is our time to soar. We are an unstoppable force, of innovation and academic excellence, solving the world's mysteries through research, stimulating growth in our community and beyond, and inspiring the next generation of leaders to build a better future for all of us. We are the University of Louisville. Watch us take flight.
My name's Natalie. I'm a junior studying communications at the University of Louisville. UofL has given me mentorship opportunities. I'm in the honors program. I've had a lot of opportunities through that. I got involved in Greek life. I'm a Cardinal Ambassador, so I get to show people what I love about our university. And then I'm also on the student orientation staff, so I get to work with the incoming freshmen and calm any of their nerves about college, and just show them my passion for U of L and hopefully transfer that to them. Family is really what it's all about here at U of L. Go Cards!
And welcome back to U of L Today with Mark Hebert. Daniel Krebs is a history professor with a passion for U.S. military history. He's here to share some of that passion with us. Welcome, Daniel.
Well, hello there, Mark, and thank you very much for having me.
All right. How long have you been with the university?
I've been here since 2007, so I got here right out of grad school and was excited to get this job, and really loving Louisville and enjoying being here.
Where are you from?
Originally, I was born and raised in Germany.
Okay.
So that's why
Military
you hear the accent. No, actually, I'm German.
Okay.
And I am in the German army, though. I'm in the German reserves to this day. But yeah, I got my PhD in the U.S. at Emory University in Atlanta, and yeah, got the job here in Louisville in 2007.
Okay. Now, you have a specialty or a special interest, I guess, in military history. Is that the kind of classes you're teaching at UofL?
Yeah, I mean, military history is really something that I focus on. And for me, you know, when we look as historians at society and history, we try to identify what happened and how and why. And for me, really, the military or warfare in general is that agent of change that really drove history. And my interest in the United States or America in general. And that's where most of my research is, and also my teaching. So I teach, you know, colonial America, revolutionary America, and also a military history survey course.
Well, you may get my son in one of your classes because he's a history major, so he may wind up in one of your
classes.
Oh, absolutely.
At some point. He's a sophomore. Send him in. Send him in.
All right. All right. Well, you've written a couple of books. You said you're German. You're born in Germany, German citizen. You've read a couple of books about German prisoners of war during the American Revolution, right? I
wish it was just, you know, a couple of books. It was just one book, but I was very excited about it. Yes, it's true.
Tell us about that. What'd you find?
It's those infamous Hessians that you guys probably heard about. So those German soldiers that the British employed for the fight against the American revolutionaries. And I looked at prisoners of war. The simple reason is military historians, they have done a good job over the last few decades to really study war. But what I was interested in is what's happening after the battle, after the fighting. And prisoners of war give us a good lens in that kind of very complex aftermath of fighting, aftermath of war. And so looked at these Germans and how Americans treated those Germans. And it was interesting to see that these soldiers were more useful enemies to the revolutionaries than just, you know, these soldiers that you put away in some kind of camp and you know, today we imagine prisoners, you know, camp and barbed wire. But that was not the case for the revolutionaries. The revolutionaries saw in them opportunity. They saw them as potential laborers. They saw them as potential immigrants. They saw them as potential, well, if you will, they used their treatment, and the Americans treated them relatively well. They used that kind of good treatment of prisoners to bolster their legitimacy in the war, so that the enemies would not see them just as a bunch of rebel force, but
as really bad guys, but fairly compassionate warriors.
Exactly, and so that was an interesting project for me in finding, and I was excited that it was published then.
All right, well, let's move forward a few years here. Let's talk about the Vietnam War. What impact did the Vietnam War have on Americans' view of wars and the military, in your mind?
I mean, my involvement with the Vietnam War really had to do with the university's Vietnam War Commemoration Committee. We're doing a 2-year effort where the university is really trying to show that we are honoring Vietnam veterans and their family members. And so the university asked me to chair that committee. And the Vietnam War, what I see here is the Vietnam War is obviously a failed effort by the United States. And we have that defeat. And that was that was tough for the United States, for its society. A rift went through American society because of that war. Not only, but to a large extent, the war in its long-term effect and efforts really is something that is with us to this day. I mean, just recently you saw, the discussion surrounding the service by Senator McCain in Vietnam and the accusations leveled against him. A few years before that, when Senator Kerry, now Secretary Kerry, and his war record was questioned during presidential elections. So the Vietnam War in its long-term effort is still with us. For militarily, we changed from a draft army to a volunteer force, and nowadays we see discussions around the separation between society and the military because of that volunteer force. Nowadays we often talk about the distrust of government, and when we trace the origins of that distrust of government by Americans, we can really go back to the Vietnam War and see how it really originated in that, and of course then with the Nixon presidency, is one of the sad chapters of American history.
We're talking to Daniel Krebs, who's a history professor at the University of Louisville. So in your mind then, the Vietnam War had a dramatic impact on the American psyche.
Oh, a massive impact. I mean, it changed American society, it changed American politics, and it, as I said, to this day, we're feeling, and this war is in many ways still with us. So yeah, one of those wars where warfare is that agent of change.
Even taking over the 200 plus years that we've been a nation, how would you fit Vietnam? Where would you rank Vietnam as the impact? I mean, the American Revolution obviously probably would be rated the biggest thing, but what would you say about?
It's one of those chapters in American history where America was not at its best, where we were struggling, where Americans were in many ways on the wrong side of history, if you will, and in that sense, it's a very important war to study. It's not the Revolutionary War where we established the United States. It's not the Second World War that really where the United States led the effort to free the world of totalitarianism, and it's not the Cold War where we stood up against the Soviets and communism. It's that moment when America really went into a conflict struggling, and then left that conflict as a defeated force.
I told you I was going to ask you a gotcha question because you aren't going to be able to answer it very well, but I'm going to try anyways. 40 years from now, as a military historian, how will you look back, or how do you think folks will look back on what happened in Afghanistan and Iraq?
Well, I mean,
like I said, the thing is, yeah, I know.
The thing is, as a historian, we tried to look into the past and find out how and why something happened. So speculation is not really my forte, I should say. But on the other hand, as a military historian, what the military historians really try to do is a little bit tease out, some of the lessons of the past, hopefully, avoiding mistakes in the future. And what Iraq and Afghanistan, to me, really showed us is a little bit over the last few years, America maybe has been relying a little bit too much on the military for its foreign policy. Because what we find out, especially in the Middle East, is that the U.S. Army is not maybe not the ideal foreign policy instrument. Okay, because the U.S. Army, when the U.S. military in general, what they're good at is mobility, is maneuver, is firepower. That is what the U.S. military does extremely well. But these are things that in the Middle East, in that situation, is really too blunt a tool and instrument, and so that might be one perspective that 40 years from now where we look back at that conflict.
Daniel Krebs, history professor at the University of Louisville. Thanks for being with us. Appreciate it.
Appreciate it. Thank you very much.
All right, before you go, did you know? It's always an interesting tidbit about UofL that we try and include in these shows. Right. UofL sports fans will like this one.
Okay.
Did you know that the UofL Cardinal bird is named Louis? A lot of people knew that. and that the bird's first costume was simply a cloth head worn by a U of L cheerleader in 1953. Now, these days, Louis' full-body costume weighs about 50 pounds, and the always-in-demand bird does everything from skydive to keep up his own Twitter account at Louis the Card. So there you go. So
I did not know that.
You've learned something today.
I'm going to say hi to Louis.
There you go. All right, thanks for joining us today. You can find the podcast of these U of L Today programs on soundcloud.com/U of L. You've been listening to U of L Today with Mark Hebert on 93.9 The Ville.